Let me record this. What time is it? Pakistan is actually 9:30, quarter past nine. It's quarter past nine. Quarter past nine. Yeah.
9:20.
Yeah. Quarter past nine. Shall I say? So, okay, let's start. Bismillah ar-Rahman ar-Rahim. Right. Tissue engineering, endodontic strategies. Let's see what different information are we able to accumulate. So we have covered a lot of topics in this course. So yeah, and today we're going to look at tissue engineering strategies in endodontics. And this is one of the fields that has already been using a tissue engineering strategy, which is a biological strategy of actually triggering uh, uh, they adapt a clinical procedure in which they want the apex to be developed, to be formed, uh, and they've been using as that clot method. They trigger bleeding and hoping that some sort of regeneration takes place. But having said that, uh, there is, the reason that regenerative endodontics remain difficult is not because we lack those biomaterials. It is because we are trying to regenerate a very, very small and very highly organized neurovascular tissue. Okay. So as we know, the pulp is made up of, what is the pulp made up of, by the way? What kind of cells do you see in pulp? What kind of cells do we see in pulp? Come on, guys. Anything. Right. So pulp is filled with undifferentiated mesenchymal cells, MSCs. They're fibroblasts. Pulp actually houses the odontoblasts as well. They're macrophages, they're neutrophils, and they're leukocytes, erythrocytes. So it's just a mixture of this. Is very heavily vascular tissue. So I would emphasize the sequence dependence, that there's a certain that, well, what you can see on your slide here, there are four biological bottlenecks. Okay. Uh, Clinically, the endpoint is no longer to fill the canal; it is to recover the functional tissue compartment. So we are really trying to regenerate the lost tissue, and triggering bleeding has had some success in the past. But what we are trying to do is we're trying to do true repair, sorry, we are trying to mimic true regeneration. Okay. And the canal biology is not helping us because it's kind of an end organ. So pulp is considered as the end organ. It is not connected with any other organ. It's just housed inside that compartment. So as you can see that, sodium hypochlorite, EDTA, and, these other medicaments are used. And intracanal medicaments have been used in the past. Sodium hypochlorite is a typical example of the bleach that you use in your laboratories. Is simply ethylene diamine tetraacetic acid as well. And intracanal pH must suppress microbes while preventing. So, people have used these, and alternative strategies have adapted antimicrobial flushing agents. Okay. Another bottleneck, as you see, is since this is also why the field is expanding into mature teeth, not just teeth with open apexes. The mature teeth are clinically very important because they are biologically more demanding, because of the open apex. Uh, and our advantage is reduced because we cannot try or test things. And this is precisely where, better biomaterials, cell strategies, and, now they've started using artificial intelligence guided case selection. And this is sometimes really, really helping scientists to develop modern strategies. Now, the another bottleneck that we have is the dental pulp stem cells, SCAPs, like population stromal cells, endothelial partners, or uh, or delivered MSC needed access to the canal space. So if you are actually trying to flood the canal with these multiple cell lines, and you're trying to build microvasculature network, and you want it to be relatively faster, okay? Uh, Another factor over here is the canal anatomy. Canal anatomy kind of, as tissue engineers, are focusing on single root canals, and then uh, multiple canals, or lateral canals. They don't really help tissue engineers a lot. We are actually targeting just simple canal anatomy for regenerative, and there hasn't been a lot of success in there. Okay, so organized function, not just tissue fill. So what for a tissue engineer, you want to reorganize those fibers, those neurovascular bundle as well, because the pulp is not just stem cells, not just fibroblasts or neutrophils or MSCs. It also houses the neurovascular bundles, the A delta fibers, the C fibers, um, and as we know that the odontoblast nucleus is actually lying within the pulp, and the tubules are spreading out. That is why you've got so much deposition of secondary dentine throughout life, because of continued deposition. So when you're reorganizing or regenerating the pulp, you want all these cells to be present in there. And the goal is a vascularized, ideally innervated pulp-like tissue with an odontoblast-like interface and durable host integration. This is what we mean. So yeah, right. Let's go ahead. Now, from repair to true regeneration, what is the end point? What is the last full stop that you will place on the story? Like, is this just you're repairing tissue, or is it true endpoint? So some of this is actually very important, because it you can see these four headings that I put down here: symptoms resolved and apical healing occurring, root wall thickening and root length gain, positive sensibility and perfusion, and histologic pulp dentin complex formation. So this is called as true regeneration. We're not just repairing, we really want the pulpal tissue to be as it was before it got infected, or it got went under apoptosis or necrosis. Okay. So, and the most common clinical outcome today is still somewhat between level one and level two. So, symptoms are resolved, apical healing, root wall thickening, but we lack that histological pulp dentin complex. We lack in positive sensibility and perfusion. So, the tissues that we develop as a tissue engineer by tissue engineering strategies that have adapted, whether electrospinning, freeze gelation, growth factors, VEGF, or angiogenic growth factors, they really lack histologic pulp dentin complex, exactly true histological regeneration, and the pulp sensibility. Okay. The system, the strategies they have adapted, they are able to resolve the symptoms. They are able to cause the apical healing and the root wall thickening, and at some point, root length gain is also possible by using bioactive glass or hydroxyapatite base, or calcium hydroxide, and even MTA has been used. Or how many of you use MTA in clinics? That's a good question.
सर मैंने यूज किया.
Yeah, you have fun in using it. Do you like using MTA?
सर आई हैव यूज इट.
सही है, नहीं आपने मजा आता है? Is it
यस सर.
हैंडलिंग में कैसा है? How is the prognosis?
हैंडलिंग में अभी इतना अच्छा नहीं है, क्योंकि उसका सबसे बड़ा इश्यू यही है कि उसको मिक्स करके और प्लेसमेंट करना इट्स नॉट द इजी जॉब।
Yeah.
ठीक है, सबसे बड़ा मुश्किल उसमें यही आती है
Mm,
इसमें।
mm.
और मिक्सिंग इज अ सिंपल डिस्टिल वाटर एंड
Yeah.
और उसमें
Yeah.
मिक्स करें और फिर आप फौरन उसको इंसर्ट करें।
Yeah.
और सेकंड थिंग इज द इशू इज द
Yeah.
ड्राइनेस, कि उसको यू हैव टू वेट फॉर द ड्राई, कि वो और उसको कंप्लीट हार्ड होने के लिए एटलीस्ट 24 आवर्स चाहिए होते हैं।
Mm. Or prognosis?
सर ये इश्यूज हैं एमटी के। प्रोग्नोसिस आई फाइंड इट गुड वन, नॉट बैड।
Mm, mm. The prognosis is
अच्छा रिजल्ट
excellent.
मिला है मुझे, मतलब एफटीए की वजह से।
No, clinical studies have
जी सर।
supported the evidence that MTA is an outstanding biomaterial, although it is just literally Portland cement modified tricalcium cement, and Torabin all the way from Torabin Jad when it was invented. So it is so basically
हम्म।
shown excellent results. So yeah, so handling issues are still there. So we
सर
want
रिजल्ट बहुत अच्छे
something.
हैं, यस
Uh,
आई डू एग्री विद यू विद योर
uh,
पॉइंट्स।
uh. Yeah, handling is, I wish if it was there was a strategy or a way. There have been some patents that some of the clinicians or endodontists have actually devised some devices to deliver, but it's still there hasn't been much success in improving its handling.
सर यस सर, वो डिवाइसेस भी हैं, वो जस्ट लाइक जैसे मलगम गन होती है उसी की तरह होती है,
Yeah,
लेकिन
yeah,
इसकी जो गन होती है बिल्कुल नैरो होती है, बिल्कुल
yeah,
बहुत
yeah,
पतली होती है, तो
yeah,
उसका प्लेसमेंट करना ही सबसे मुश्किल काम है।
yeah. So
लेकिन सर
let's
आप इन्वेंट कर दें सर कुछ ना कुछ।
नहीं, थैंक यू, नहीं आप करेंगे। I've crossed. It's your time. You people are in it. And I think for me, honestly, there are other avenues that are more exciting. Yeah, I like innovation. I like innovation, but yeah.
यस सर।
Shelly, let's talk about some numbers now. We have made a good case. Endodontic strategies, regeneration strategies have been used. सही है. They are doing it, but full regeneration नहीं हो रही. So let's talk about some numbers. You know, the evidence base for regenerative endodontics is still improving. But we still need to separate. The success rate from the biological certainty. That is what we really want. The true success. Okay. So the first message is that we now have a reasonably sized uh, understanding of for the key questions through a number of different meta-analyses, and one of them is this first in which they've used REP, stands for regenerative endodontic procedures, and this was a pool of around 32 studies. There was a meta-analysis conducted, and in which 32 studies, there was a pool of 32 studies, and it showed that antibiotic paste was associated with more dentine wall thickening, while calcium hydroxide was associated with more apical closure. Okay, so have anybody used antibiotic paste in the clinics?
सर मेटापेक्स यूज किया है।
Meta paste use here. Okay, what are the contents
और
of meta paste?
is a metapex is basically the calcium hydro non-setting calcium hydroxide.
Calcium hydroxide, but it's not an antibiotic, isn't it?
Yes, it is not actually the
No, it's
antibiotic,
calcium hydroxide.
एंटीबायोटिक के लिए।
Hmm.
पर इट्स वर्क एज ए बैक्टीरियाइडल एंड
Hmm. Hmm.
सेकंड इज अल्कलाइन करता है, तो सर उसकी
Hmm.
वजह से वो
Hmm.
बैक्टीरिया ग्रोथ नहीं होते, और बैक्टीरिया
Hmm.
ग्रोथ नहीं होते तो वो बैक्टीरियाइडल एनवायरनमेंट क्रिएट कर देता है।
Correct.
दूसरा सेकेंडरी डेंटिन फॉर्मेशन करता है, ठीक है,
Correct.
बिकॉज ऑफ द कैल्शियम
Correct.
डिपोजिशन होती है, तो सर
Correct.
डेंटिन फॉर्मेशन करता है ड्यू टू
Correct.
द इटसेल्फ, और ब्लड से भी वो कैल्शियम वगैरह लेके और सराउंडिंग से भी कैल्शियम लेके, मतलब टूथ स्ट्रक्चर से भी कैल्शियम लेके फिर वो दोबारा रिफॉर्मेशन, सेकेंडरी
Correct.
डेंटिन फॉर्मेशन।
So, you know, uh, while calcium hydroxide has been used and it has shown excellent clinical results, this current meta-analysis जिसके बारे में मैं discuss कर रहा हूँ, in which 32 studies were used, they used antibiotic paste, and what they noticed was that caused dentine wall thickening. And the calcium hydroxide, this specifically was reported for an apical closure. Okay. So what this actually suggests is that our disinfecting strategy actually it actually influences uh, the outcome, and it's not just about sterilization. Okay. uh, and so disinfection and I've given an image below which shows uh, disinfection protocol signals and different outcomes. And one side is showing calcium hydroxide and it's showing your dentine wall thickness, antibiotic paste showing 66, and calcium hydroxide showing 53. And that is the number of cases reported to show dentine wall thickening by using antibiotic paste. As compared to apical closure was seen more in calcium hydroxide, and there were 88 cases reported for that, as compared to antibiotic paste, which showed only 66 cases for apical closure. Another study, जिसके अंदर they have used this that there was evidence accumulated from a meta-analysis again, and they were talking about scaffolds in there. So 14 randomized clinical trials were pooled in that, and there were around 430 participants. And the strongest signal for root length change was change rather than the universal superiority across every endpoint. So what I'm trying to say here is that uh, over the period of, and I've actually cited and I've given you a QR code. You can actually go onto the scientific paper that and read more on it, because the there are three papers over here: Alhini, Arslan et al., which had a positive pulp response. Seal bioclinical success, that's a more from the product side. Um, but know that the limitation evidence quality is still moderate. Protocols are heterogeneous and sample sizes remain small. So whatever clinical and randomized control trials we are accumulating from literature, they tend to show that the strategy works of calcium hydroxide, of MTA, but again, it's more targeting towards dentin. Okay. We are now talking about regenerating the pulp, regenerating innovation. Okay. Uh, and the last two percentages that you're seeing, around 93.9%, 55%, the 12-month regenerative endodontic procedure success in one of the mature tooth. There was a randomized study about that. And again, 55% of regenerative endodontic procedure cases regaining sensibility in the same mature tooth trial. So these studies, which actually, as you can see the numbers down as well, by Elhini et al. And Arslan et al., they were really landmarks in showing that the regenerative endodontic strategies actually work. Okay, but they were targeting somehow the dentine. They were targeting not complete true regeneration. But again, this was one step closer to talking about complete regeneration. सही है. Uh, okay, so when you get time, go through this QR code. Let me see if it works. Let's see if it works. I hope it works. Sometimes they don't work, and then I get messages in the back. Yeah, it leads you to the PubMed article. Yeah, that's by Arslan in Journal of Endodontics. Yeah. So yeah, when you get time, look at these papers, these two papers specifically by Alhini, in which uh, what they mentioned was one of the Arslan actually et al. Mentioned that regenerative endodontic procedures have the potential to be used as a treatment option for mature teeth with large periapical radiolucencies. And this was not very long ago. I think the paper was published in 2019. So this is very current evidence. 2019, almost 7 years ago. So not that old. So what is our interest today? Where are we at? So yeah, a biomaterials framework for regenerative endodontic therapy, or RET, from a classical triad to a clinical pentad. So what we are really looking for is the triad of scaffold, cells, and growth factor. So we are looking at something which is more clinically executable regeneration. पेपर्स तो बहुत हैं, लिटरेचर भी बहुत है, स्ट्रैटेजीज भी बहुत है, बट अगेन ट्रू रीजनरेशन जो है ना is is rarely being reported or seen, but we are getting there. From what literature suggests is that we are getting there. So what we know is that cells, scaffold, and signals, these are the main thing. Okay. The classical triad of tissue engineering that we have repeated over and over again in almost every seminar that we have had. But I usually tell clinicians that endodontics forces us to extend it. Endodontics tells, okay, you can not just rely on scaffold, cells, or signal. You need something more in there. Okay. Uh, we know that sometimes, the canal becomes contaminated, it's closed, it's very less diffusion in there. Therefore, the vascular control and the immune control, are very difficult in there. And this is the central design of from becoming a triad to a pentad. So we are looking at not just scaffold cell signals, we are adding vascular immune control in there, and we are also adding a digital AI layer. This is what we are scanning and what we are adding to the pentad, and we are expanding how we think about regenerative endodontics. And and lately there's a, and not just in Journal of Endodontics, and you see a lot of papers. I've cited a few papers in here as well, which have shown the potential of artificial intelligence as a fifth element. Okay. And I'm not hyping it up, because I'm sure you know that there's a lot of hype to it. But does it truly affect the understanding and the decision making of tissue engineers for regenerative endodontics? Okay. Once protocols become more complex, and the reproducibility, patient selection, the rationale of using a certain biomaterial design, they become more computational problems rather than more biological problems. So you need to take these things into effect. आपने इनको understand करना है कि biological problems क्या है. You have to feed them into, make some understanding of it, and you're able to predict patient stratification, scaffold optimization, and protocol standardization. So I'll give you an insight. This is what I did. In the past few weeks, I started to learn coding. And coding, what I started saying, like, say for example, you are PhD students, and you don't have to go through the literature. You have a platform in which you can write down. I have a patient for, say, 25 years old. He has this problem, clinical problem. These are the periapical OPGs, and these are all it's the files. Suggest me the regenerative strategy for this disease or condition. Okay. So I wanted to code this. I said, if this can be coded, to sare just tissue engineers हैं, which are always digging through literature. So what AI has is this understanding of a lot of literature in the back of its mind. It will utilize that, and it will tell you, okay, strategy one, strategy two, and strategy three. These are the three strategies you can use. This is the right scaffold based on evidence. This is the right testing you need to do, and so we did code something, and I was able to make a little pilot uh, code for that. So I will share with you बाद में, inshallah, when I get the time. So right now I want you to understand that from triad we are going on to a pentad. uh, so whenever you evaluate a new regenerative endodontic therapy, ask 5 questions. you're going through Journal of Endodontics, and you're seeing, oh, look, and there's some, they're talking about regenerative endodontics. So for always dig in the literature for these things. Always ask what cells have been used, or what cells are present in the study. Okay, what scaffold occupies the space? मतलब scaffold की degradation कैसी है? What is the shape of the scaffold? Is it a hydrogel? Is it a pH sensitive gel? Okay. And what signals are delivered in the cells? Okay. And how the vascular inflammation constraints are handled. This is something very important because the vascular constraints are the biggest challenge in regenerative endodontics. And the last thing is how reproducible or personalized that strategy is. And we have been talking about this in the past. हम लोग बात कर रहे होते हैं precision medicine की, personalized medicine की, not one size fits all. We want to bespoke our endodontic procedure, a regenerative endodontic therapy just for that patient. So yeah, so this is where uh, this the our common understanding of a triad changes to a pentad. Okay. Now, cellular strategies. The this is something really important. Choosing the right cells. Uh, I've written down some, some advantages, some limitations. You can uses induced bleeding and endogenous stem cell progenitor cells. What you're trying to trigger is undifferentiated stem cells, so that can differentiate into the cells that you want. Um, Procedurally simple and regulation light. So regulation light, as in whenever you are devising a regenerative therapy and you're taking cells into consideration, always make sure that the regulatory authorities or the bodies that are involved in devising and that are, then there's not a lot of red tape around it, because using certain cell types can, you will be asked questions about it. What are the limitations? Are uncontrolled cell identity and dose. How much of cells seed will you seed actually? How much of cells do you need? Okay. Can you also change the phenotype of the cell? क्या आप सेल का जो कैरेक्टर है वो बदल सकते हैं कि नहीं? Okay. Can you tune it? Can you give certain growth factors? Okay. Uh, Weak early vascularization in long or mature canals often trends toward repair rather than organ level regeneration. So whenever you use these strategies, करते हैं, तो the end result is usually repair. You don't see complete true regeneration. So, having gone through a lot of literature, there was a paper by Ber, Berzuela et al. Okay, and this was one of the very founding papers on the clinical. It was kind of a clinical proof of concept, in which they used 36 mature teeth and showed no adverse events, 100% clinical efficacy at 12 months, uh, perfusion rising from 60 to 78%, cold test positivity. So they conducted a regenerative uh, endodontic procedure, and the outcome of the procedure was fantastic, was game changing for the people who were talking about regenerative endodontics. Okay, what they were talking about basically was, and they were looking into cell transplantation, and they actually were at the phase one and phase two of their trial, and they were using, I think they were using umbilical cord MSCs, okay, and they were using allogenic umbilical cord MSCs, and they were using it in a sort of a plasma derived biomaterial, okay. Now you know that plasma has the potential for being used in regeneration a lot. There are plasma centers all around in the city. वहाँ पे आप plasma donate भी कर सकते हैं. Has anybody seen those plasma centers? Do you know of the plasma therapy? किसी ने देखे?
नहीं सर, मैंने तो नहीं देखे, बाकी मलिया वकास का पता नहीं।
I don't know कि मुझे मुझे तो ये नहीं पता कि पाकिस्तान में है कि नहीं, लेकिन आई एम प्रिटी श्योर कि होगा कि प्लाज्मा आप जाके डोनेट कर सकते
सर
हैं.
क्या नहीं है सर?
प्लाज्मा.
प्लाज्मा तो होता है, पीआरपी वगैरह, पीआरएफ वगैरह हम यूज
है ना?
करते
नहीं
प्ल-
सर, कह रहे हैं कि डोनेट कर सकते हैं, ऐसे सेंटर्स हैं।
हम्म।
हैं। मेरे ख्याल में आप ब्लड डोनेट कर सकते हो, तो प्लाज्मा उसी में से निकाल
बिल्कुल,
लेते हैं, कोई इशू तो नहीं है
एब्सोल्यूट,
मेरे।
बिल्कुल, एब्सोल्युटली। जैसे आई गिव यू।
ब्लड डोनेट करते हैं क्योंकि मैंने ये इसलिए कह रहा हूँ कि डेंगू वगैरह होते हैं तो ज़्यादातर लोग जब प्लेटिलेट्स उनको चाहिए होता है, तो सर उसको सेपरेट करके फिर वो इन्फ्यूजन की जाती है प्लेटिलेट्स वगैरह भी। ये तो मैंने खुद देखा हुआ है।
सही है। देखिए, यहाँ पे प्लाज्मा सेंटर्स हैं जहाँ पे अगर जाके आप अपना प्लाज्मा देंगे, दे गिव यू $800, $800 to donating your plasma. सही है ना? So which is a lot, because the potential of plasma is still, so they are actually bioplasma centers built. I think I've been in this part of this in this city for almost 6 months. और 6 months में मैंने 2 से 3 प्लाज्मा सेंटर्स देखे हैं designated, and have seen ads उनके, they're marketing that for people to come and donate plasma. I'm sure, pretty sure that they are being used for regenerative therapies. सही है। तो
और
uh,
प्लाज्मा से होंगे, वो ब्लड डोनेशन होगी ना बेसिकली, तो प्लाज्मा तो उससे सेंट्रीफ्यूज करके
जी
उसको
जी,
ड्राइव
करेक्ट
करते हैं।
करेक्ट करेक्ट, but they are actually advertising it as plasma centers. Yeah,
ओके।
you're right. But yeah, I'm sure they are donating, they're taking blood, but yeah, they're saying we are give your plasma.
हाँ।
तो ब्रिजुएला ने जो फेज 1 एंड फेज 2 ट्रायल किया था, दे यूज एलोजेनिक umbilical cords in a plasma derived biomaterial, and they use it for mature teeth with apical lesions. सही है ना? So this trial was a game changer, as I said. It was a landmark. It is so important, not because it solves the problems that we are talking about, but because it proves that there's a feasibility, there's a safety, and there's a sort of a measurable functional signals in hard clinical scenarios, such as mature teeth problems that we mature teeth with open apexes. So showing that umbilical cord with plasma dry biomaterial was able to regenerate it. But I would stress uh, one big lesson from biomaterials literature here, that the survival of the biomaterial is not enough on its own. We need vascularity. We need vascular partners. Okay, and having said that, not just one type of cells. You can have co-cultures, and I've given you certain cells, dental pulp stem cells from the apical papilla, shed, BMSCs, undifferentiated MSCs, and the trade-off is between better biological control but higher GMPs, manufacturing liabilities, banking, logistics, and regulatory burden. Just like, if you remember कि exosomes की जब बात हुई थी, तो उन्होंने कहा था exosomes, you can almost recruit them from every cell type. Similarly, यहाँ पे भी सेल बेस्ड ट्रांसप्लांटेशन थेरेपीज में जो कि यूज हो रही हैं, स्टेम सेल ट्रांसप्लांटेशन थेरेपीज जो यूज हो रही हैं, उसके अंदर द सोर्सेज, so there are a lot of barriers for using them in clinical situation, clinical scenarios. सही है? Okay. Now, as we were talking about cell-based transplantation, which offers better control over phenotypes, scaffold loading, and signaling. Most clinically interesting when the endogenous cell reservoir is inadequate or the canal is biologically hostile. That means you can use different cell types and different cellular strategies to achieve what you want. Yeah, I think I had one more thing. So this leads us to what is the next step? सही है ना? हमने तो बात कर ली कि okay, the study used MSCs. There was a plasma-derived biomaterials, open apexes. Now these were phase 1, phase 2 trials actually. So they in the evidence-based data, phase 1, phase 2 trial are considered top quality evidence. So what is the next step here? The next step is monocultures are rarely enough. That means, say, you cannot use single cell. Monocultures matlab single cell line. Okay. and multi cells can be used, or co-cultures can be used. So endothelial co-culture and pre-vascularized constructs consistently improve survival, differentiation and network formation in vitro and in vivo. That means कि आप एक सेल टाइप यूज नहीं कर सकते, आप उसको 2 या 3 सेल टाइप्स आपको यूज करनी पड़ेंगी to achieve proper vascularization, and when you're talking about true regeneration. Okay. And what is the emerging evidence pointing us? If you remember, Kuch, I think a few weeks ago when we were discussing either bone, we talked about gelma, which is a biomaterial, kind of a hydrogel. There was a study which used gelma hydrogels and the encapsulated shells and human umbilical cord vascular endothelial cells, and they were able to form mature microvascular networks with 11 one in one co-cultures. That means that the seeding capacity of दोनों cells was equal, 50-50 थी. मतलब जितना cells उन्होंने से sheds use किए थे, they used HUX in the same concentration. Okay, giving the strongest pre-vascularizations. That means they were able to see some mature microvascular networks, so which is very fascinating. Now the challenge comes: were they actually able to do it inside a small, tight space? Okay, and turns out the evidence suggests yes, they were able to do that. So microvascular to ban raha hai in vitro studies. Uh, what is the next step to it? So I've just written down some resources of the jo kuch abhi you have seen in the past slide is taken from these. So make sure whenever you get time, if you want full text, okay, give me a shout out. I'll share with you. So scaffold strategies, what works clinically now and where the gains really are. सही है ना? हमें क्या पता है कि कौन से scaffolds are actually, what is our understanding कि which scaffolds have been used in the past, and where is the potential? What we have found out from the literature earlier, that plasma-based biomaterials were working, monocultures were not suggested, co-cultures were suggested, co-cultures were more targeted. Uh, current current evidence यही कहता है कि blood clot strategy जो use की है in clinics, that has certain strength and constraints. The strength is that it's very simple. Every endodontist or a general practitioner can trigger that blood clot carefully. It's low cost. Still, it's kind of considered as a clinical benchmark. What are the constraints? It's variable architecture, difficulty, low bleeding cases as well. So this is just a little highlight. Then PRP, PRF, and collagen-based HA have also been used. Okay, this is the current landscape. Okay, uh, there was a meta-analysis which was conducted in took this information from 2025. There was a meta-analysis conducted, and meta-analysis is that if you're studying the hierarchy of evidence of scientific literature, the meta-analysis is right up there at the top. This when blood clot remains the preferred primary scaffold, platelet concentrates are responsible adjuncts when intracanal bleeding is limited. So, so what they said that even till now, okay, जहाँ पे इतनी literature हुई है, इतना science, cutting edge science has been changing the landscape of regenerative endodontics. Monoculture से co-cultures पे आ गए हैं, but 2025 में, which is just last year, the evidence still suggested that by blood clot methodology remains the preferred primary scaffold, and platelet concentrates are reasonable adjuncts when intracanal bleeding is limited. सही है, तो आप platelet concentrates use कर सकते हैं. But again, I've given the strengths and the limitations over here. Okay, the about the PRF, about PRPs. Now let's look at it from a different angle. This is a very biomaterial consistent result. Okay, that structural remodeling हो रही है, biological healing हो रही है, and are they are actually correlated, but the structural remodeling and biological healing, should have the same outcome. Okay, structurally, it's making the microvasculature, okay, or refilling that space, and biologically, it is creating innovations as well. Sorry, excuse me. So as I said, the meta-analysis was one of the evidence which was used in the content that you're seeing on this slide. Um, the other thing that I wanted to point out that I've given up here that so the scaffold question is not which material wins universally, but which material best supports the biological deficits in this case. So we are actually targeting. हम ये नहीं देख रहे कि whether it's a chitosan, whether it's a polylactic acid, a polyurethane, or whichever polymers and degradable natural synthetics. We really want to overcome the biological deficit here. That is the biggest challenge over here. Uh, there was another study in which they use collagen, or they use a collagen scaffold or collagen hydroxyapatite, and they showed that it may be more useful when they pair it up with the signal or a cell source. So, for example, they use collagen with hydroxyapatite, and they added it with s- certain cells, a source, and they used it as a passive. Imagine अगर आप MTA use कर रहे हैं and you have taken out the plasma or the PRF of a patient, और उसके बाद आप उसके अंदर you're creating a blood clot. You're using MTA for the apical closure, and in order to revascularize the tooth, you're not just creating the clot, you're using patient's own PRP, PRF strategies in there. So the Northstar human extraction study is there was a study concept done by Nusrat. Uh, I think Nusrat. I don't know what year it was. It was a human extraction study, and it was really important. And it actually showed that scaffold alone was not enough, whereas scaffolds plus blood clot produce a more interesting intracanal heart tissue outcomes. But again, these literature जो कि बात कर रही है ना, sometimes what regenerative endodontics engineers sometimes they fail to understand is that it's not just heart tissue is biologically so challenging that you're trying to regenerate the vasculature as well. Sometimes they focus on heart tissue. Okay, apical closure करा दिया. What about the biological tissue? और अगर biological tissue बन गया है, तो is it innovated or not? Is it well innovated? Has the tooth regained its innovation completely? So it's very challenging. Again, there was this was a study. Root length signal is where the scaffold choice matters. So how long the root is, it also can change the strategy you adapt for regenerative endodontic. So what they did was PRP versus PRF, and this is kind of an odds ratio for greater root length increases. So they use BC versus PRP, which they used. I think it was a biological composite versus PRP, and they showed kind of better odds ratio in this paper. And I've actually cited all the papers at the end of this presentation कि जब आप लोग जब ये खत्म कर लेंगे ना, and so whatever I've said today is from that evidence. So let's talk about exosome one more time. I don't know what happened here. I think I have added a picture which is not showing. I took it from the image. So we know that exosome have been used in periodontal tissue engineering, periodontal regeneration, a lot. And we are actually shifting from scaffold-based strategies with using, from using single molecules toward multiplex biological constructs. So we're not just one molecule. We are using a very complex biological instruction, which tells the remaining undifferentiated MSCs to differentiate. This is really important क्योंकि the pulp dentine complex is not just one signal in view, it emerges from, there are reciprocal interactions between mesenchymal tissues, endothelial, the neural, the immune, and also dentine-derived cues as well. So it's a mix of tissues. Uh, we have talked about exosomes in the past, and we know that they are really exciting. Specifically, there are some papers. There was a there was a paper in 2025 again, which they had odontogenic exosome paper tha. And it is very interesting in a way because they use these vesicles, they were harvested from dental pulp stem cells. So exosomes were harvested from dental pulp stem cells. And if you remember, Dr. Paras jab baat kar rahe the, when he was presenting, and I think one of you asked a question कि depending on the tissue जहाँ पे regeneration हो रही है, अगर वहीं के सेल से exosome harvest किए जाए, तो the impact of regeneration would be different there. Okay, say for example, bone का कर रहे हैं, तो bone marrow से अगर लिए जाएं, not कि आप human umbilical use कर रहे हैं या dental pulp use कर रहे हैं bone के लिए. तो if you remember, somebody asked a question, I don't know कौन था, so the same strategy goes here. And the paper that I looked into used dental pulp stem cells, and they extracted exosomes from dental pulp stem cells. And what they were actually see was they were able to trigger odontogenic differentiation. Not just that, but they retain their stemness as well. मतलब कि वो अपनी stem cellness जो थी उसको retain किया, and having that stemness, they release those exosomes. So what investigators have done is they've actually tried to capture this strategy and produce more papers on exosome. But again, this has been tested and tried, and there's a long way to reach the clinical world. This is sort of a preclinical world at this point in time, preclinical EABB. But having thought about it, it can actually give us insights of how we can tailor, we can change, what we can use exosomes for regenerative endodontics. Let's talk about spheroids. Has anybody heard about what spheroids are? Spheroids सुना है क्या होते हैं?
नहीं सर, स्टेरॉइड्स का नहीं सुना है सर।
With spheroids, I think I have to step back a moment. When we were doing our PhD, one of our colleagues is a Pakistani था, वो spheroids पे काम कर रहा था. What spheroids are is actually there is something called as a hanging drop method. अगर आपने टिश्यू कल्चर प्लेट देखी है, तो टिश्यू कल्चर TCP plate में it has a cover on top and it has a little box. And spheroids were actually grown. Wakas, can you mute? Thank you, thank you, thank you, thank you. So spheroids में क्या हो रहा है कि the cells are actually grown on the plate. So, and they kind of it's just actually called as a hanging drop method of growing. So just like a drop of liquid sticks, because sticks onto the cover of any plate, the cells were grown into this kind of spheroidal structure. So the idea or the concept of spheroids was because they give uh, a more physiologically relevant 3D model than traditional 2D cultures. 2D cultures में क्या होता है कि आप एक simple plate में you put the cells in, cells are attaching. Spheroids में they are growing within a 3D space. So that means they are increasing in size. The drop which is hanging on top of the plate, it's growing in size as the cells are increasing. So spheroids are really, really important in regenerative endodontics, and they actually overcome the limitations of 2D cultures because a lot of studies हम लोग करते हैं in tissue engineering strategies for regenerative endodontics, they are mostly 2D, and sometimes the 3D aspect is usually overlooked. So spheroids actually overcome this, and they also call as spheroids slash organoids as well, because these spheroids can then be used uh, but if you can see the image over here, uh, this in the top right corner, and over here as well, you can see these little tiny dots, more tiny dots हैं culture media के, and each dot is a spheroid. That means उसके अंदर cells grow कर रहे हैं without being attached onto anything. बस जो उसका base है is attached onto uh, the plate. And if I invert it, it would still be hanging and sticking to the top of the plate. Now, they actually facilitate very complex communication with which is very essential for tissue healing, and they actually trigger certain signals as well. So, and if you get the time, scan the QR code and have a look at the paper which talked about spheroids in regenerative endodontics. Now, as I said earlier, कि spheroids का जो role है in stem cells, particularly scabs में, stem cells from the apical papilla. It's really important because scabs have been used to create or generate these spheroids, uh, and they've been used in the development of immature permanent teeth, and there are studies which have used it. Similarly, spheroids have also been created by using macrophages as well, so that and they've also been used to tune the macrophages so that आपने M1 to M2 tuning की हुई है. So M1 is usually linked with pro-inflammatory sorry, M1 is pro-inflammatory and M2 promotes healing. So it's anti-inflammatory. So macrophages को भी tune कर सकते हैं while they are there. Another strategy is they create cell-to-cell matrix, paracrine, juxtacrine signaling, important for dental pulp regeneration. We talked about scaffold for macrophages, SCAP. And these models, they may bridge the gap between simple in vitro testing and animal clinical studies for regenerative endodontics. So ये इसको यूज किया जाता है as a model to study other strategies कि आप spheroid grow कर सकते हैं. You can introduce a cancer producing agent in there and see how the cells react. So you're actually creating micro 3D environments, okay, and you're testing how the tissue or the cells react in there. So this is another very fascinating biological strategy in regenerative endodontics. And I think I've given the paper niche. सही है. Let's talk about dental pulp on a chip. So dental pulp on a chip, जैसे organ on a chip की बात की थी हमने कुछ अर्से पहले कि organs are being tested or drugs are being tested on small organs. They are mimicking the entire liver, entire lung, or entire glands on a microchip, and they're testing uh, uh, how the drug would actually react, okay, rather than using it on a patient. और उसके अंदर क्या किया जाता है, it combines microfluidics and biofabrication. There are two different strategies. इसको biofabrication में they create these little channels, or microfluidics में and these channels have got very small space to pass the drug or the fluid or the cells in there so that they can actually mimic. Having this thought, dental pulp on a shelf recreates complex pulp microenvironment in a controlled microfluidic system. So, when you dig literature in regenerative endodontics, dental pulp on a chip comes in as well. Uh, so it can integrate key pulp components such as HD dental pulp, human dental pulp stem cells, odontoblast-like cells, endothelial cells. The model allows real-time study of pulp dentine biomaterial interactions and under more physiologic conditions. तो आप किसी भी चीज को अगर mimic कर रहे हैं on a small scale, it's relatively easy to control the flow of the cells, the flow of the drug, or the material which is growing through these microfluidics. So I think it's better for me कि अगर मैं next slide पे आपको दिखाऊं कि what it actually is. Now this is taken from a review on dental pulp on a chip, and it's actually showing you three different studies and the target materials, the device features, and the cell materials which were used in there. So yeah, the first one was from 2014, Pagela et al. And Frontiers in Physics में publish हुआ था ये. The target was crosstalk between trigeminal innervation and teeth. They use a static microfluidic 2D chambers connected by microgrooves, और उसके अंदर they use mouse trigeminal ganglia, mouse tooth germs, and postnatal mouse tooth. The second study जो है इसके अंदर 2019 में New et al. Was ACS Biomaterial Science Engine. This is actually more relevant. And actually the last one in which if you can see the last one talks about in 2021 wali, which is very recent. Franca et al. In Journal of Dental Research में use की थी. And Franca et al. In 2020 also published a paper on lab on a chip. Okay. She collaborated with Rodriguez, and what they were able to do, they were targeting specifically pulp dentine materials interface, pulp dentine materials biofilm interface. So within the microfluidic organ or chip, they were targeting this. और इनका device क्या था? They made a static two parallel channels and a central groove for dentine connected via large groove. So, basically trying to mimic what small space the pulp would be in. And their cell material was aged human dental pulp, stem cells, odontogenic differentiation, collagen matrix. So they had a collagen matrix as a biomaterial. And I think they compared with ProRoot, Biodentine, Thera KLLC, and they also were testing it against Streptococcus mutans and seeing whether within the channel, if you can see that image on bottom left side, these channels, they were trying to mimic dental pulp on a shell, and they were trying to study how the dental pulp, along with this collagen matrix, will have an effect. So whenever you get time, if you can find those papers, dental pulp on a chip is a fascinating field. Or maybe you see regenerative endodontic procedures or therapies being tested. So yeah, so what we have seen is, I think this we actually talked about this scaffold. We talked about the root length. We talked about the biological aspects of it. I'm just going to skip it to let's talk about this. So artificial intelligence used in regenerative endodontics therapy. So having dig the literature, what I came across was there are papers coming up in that AI in regenerative endodontics is sort of uses evidence assistance and a prediction engine as well. कि predict कर सकता है कि what strategy will be used. Okay, and there was a paper which actually did this over here. AI as an evidence not suitable, not a substitute for clinical judgment, but say it was more of a evidence-based assessment. So they use different models, they use GPTs, Geminis, and they were actually showed that the correct response rate in 2025 regenerative endodontic therapy chatbot study around 98.1%. And they actually input जो उन्होंने किया था, there was 1,380 total response to regenerative endodontic questions. And the outcome is that AI can be used as an evidence assistant, but not to replace the clinical judgment completely. Now, AI के use के you can use it in a bidirectional ways in helping you as as an assistant in devising strategies. Okay, and what the current slide is actually talking about is clinical decision making, जहाँ पे you cannot rely on the clinical decision making made by these large language learning models. Okay, it can also be used for prognosis and prediction. सही है. And I will put in a QR code as well. Let me see if it works. मैं सिर्फ check कर लेता हूँ क्योंकि because sometimes the QR code doesn't work, because I'm gonna send it over to you. Yeah. So this study again was published in the British BMC Oral, I think BMC Oral Health. It's a Q1 journal, and they did the evaluation of different artificial intelligence applications in responding to regenerative endodontic procedures. Now, 268 teeth in 2025 for ML prognosis study, 0.94 random forest AUC at 1 year, and 0.86 random forest. So this is the outcome of the study. I'll try to make sense of whatever these numbers are for you people. So yeah, basically it was a prognosis paper. So yeah, which was uh, they said that it was clinically more relevant. Okay. उन्होंने क्या किया कि एक मॉडल को ट्रेन किया फॉर 198 पेशेंट्स लिए, उसमें से दे गेव अराउंड आई थिंक 250 or 260 टीथ को का डेटा उन्होंने उस मॉडल में डाला. एंड how many of you are actually familiar with AI or use AI? सब लोग करते हैं कि नहीं? Let us have that feedback first. There are three of you here. आप लोगों में से कौन यूज करता है? कोई यूज करता है in clinical or in your teaching, or do you use it?
सर क्लिनिकल प्रैक्टिस तो आई डू नॉट डू दैट, तो फिर यूज भी नहीं है, लेकिन हाँ टीचिंग में और हर चीज में ही यूज है एआई का, तो अब
हम्म
लाइक इट्स वी आर वेरी मच डिपेंडेंट ऑन इट,
हम्म
सो मच सो कि मुझे लगता है अब हमारा थॉट प्रोसेस थोड़ा स्लो हो गया है.
बकास.
और प्रोडकास्ट के अलावा सर हमारी रिसर्च बहुत कम हो गई. हम बोलते हैं हमें कोई होमवर्क मिलता है तो हम देखते हैं आर्टिकल्स मिला है उसको रीड करने के लिए, कोई समरी निकालते हैं, रीड करते हैं, हम बोलते हैं हम
हम्म
फारे हो गए. फर्स्ट वी
हम्म
हैव टू गो थ्रू ईच एंड एवरीथिंग कि कौन कौन सी बातें हैं, और समझने के लिए बहुत ज़्यादा अपनी वे आउट निकालते थे. लेकिन अब ये चीज़ें नहीं है. एआई की वजह से हम काफ़ी एक तो थॉट्स के अलावा हमारा टाइम जो है
हम्म
बहुत काफ़ी सेव हो जाता है. काफ़ी काम जो होते हैं, जो टाइम
हम्म.
कंज्यूमिंग होते हैं, वो जल्दी हो जाते हैं. ये बेनिफिट.
तो मेरा नेक्स्ट क्वेश्चन होगा कि कौन से मॉडल्स आप लोग यूज करते हैं?
सर क्लोडिया मैंने अभी शुरू किया है.
सही है.
आ, और चैट जीपीटी वगैरह, डीप सीक वगैरह, जेनी पे मैं लॉग इन हो चुका हूँ.
सही है.
तो ये
सही.
3-4 तो यूज करना शुरू किए हैं सर. ऐसा ऐसा कोडिंग भी शुरू सीखना चाह
हम्म.
रहा हूँ कि किस तरीके से
सही है.
सॉफ्टवेयर वगैरह, जैसे एंटी ग्रेविटी के बारे में रिसेंटली रीड किया था.
सही है.
आई एंजॉय,
हाँ.
मतलब वो उसको ट्राई करना चाहिए.
मेरा लास्ट क्वेश्चन होगा कि have you paid for these services? Do you have a paid version or are you using the free version?
आई एम थिंकिंग टू टेक द क्लाउडिया, लेकिन अभी तक भी मैंने पेड वर्जन यूज नहीं किया है. लेकिन क्लाउडिया पे मैंने सोचा है कि आई हैव टू टेक इट फॉर अ 1 year
हाँ.
सब्सक्रिप्शन.
हाँ, मेरा ख्याल से कि if you're thinking about it, it is a good sign at least. क्योंकि क्लॉड का जो यूजली अभी रिसेंटली क्या हुआ था कि द यूएस गवर्नमेंट में क्लॉड या एंथ्रोपिक जिसको कहा जाता है, एंथ्रोपिक,
एथ्रोपिक.
हाँ, एंथ्रोपिक started using a model which raised a red flag in the government. और उसके अंदर क्या हुआ था कि अभी क्लॉड ने वो अपना जो मॉडल है ना, they have opened it up to the public now. Now, Claude is so fascinating, and I'll give you my little insight. मेरे पास पेड वर्जन है दोनों के, क्लॉड के भी हैं और जेमिना उसके भी हैं, चैट जीपीटी के. I don't use a lot of Gemini, but what I have seen is कि the outcome of the of your query, it is so precise, so specific. और you can because जो मैं पिछले मैंने जो कोडिंग वगैरह जो भी सीखी है, जो भी किया कर रहा हूँ, and मैं I'm adding it to my teaching and learning for the students as well. So I'll give you, so it has really changed. So yeah, if you need any help, आप लोगों को चाहिए तो, and if you're going for the paid version, मैं तो suggest करूँगा कि लीजिए आप. If you're teaching, it would really change the help. It will change the way, or maybe help you and aid you in your teaching as well. Once we are finished with it, I'll show you what I've done. So what I have attached the paper over here. This was a paper about machine learning models for prognosis prediction in regenerative endodontics. This was BMC Oral Health में publish हुआ था. Again, there was another paper in, I think it was evaluation of different artificial intelligence applications in responding to regenerative endodontic procedures. So, papers are evidence is being collected on how it can help us in the, um, and this is exactly, these models are able to aid our thinking or mold our thinking, and they're not replacing it. They are just uh, helping us, giving more deeper insights. Maybe aiding it is the right word. के aid कर रहे हैं, not replacing it completely. What is the future of regenerative endodontic therapy? Okay, how we have been talking about this, and I think हम लोग जहाँ पे बैठे हुए हैं, it is very important for us to actually talk about this. क्योंकि अगर हम लोग बात नहीं करेंगे तो how, uh, this is like, I'm deliberately asking and telling you people, Kate, this is where the future is. Now, strategies तो बहुत हैं, scaffolds भी बहुत हैं, biological agents भी बहुत हैं, exosomes are available, there's data, literature, in vitro research हो रही है, spheroids भी are being, where does this lead us to? हाँ? हम लोग क्या कर रहे हैं उसका, and how can we harness artificial intelligence in devising strategies? So the most important concept over here is the inverse design. Okay, uh, we need to think that rather than having a convenient hydrogel and asking, "भाई कौन सा cells जाएगा, कौन सा cell will like it," we can start from the biological behavior, differentiate. सही है कि क्या behavior होगा, biological behavior क्या होगा, what is the differentiation timing of the cells. Okay, how can we do the immunomodulation, can we do that, इसकी release profile क्या होगी? What will be the, can it trigger any mechanobiological response? Or okay, can it trigger any mechanotransduction? सही है ना? And इसमें क्या है कि rather than going uh, top-bottom approach, approach, we are going bottom up. So we are reverse engineering the scaffolds, reverse engineering tissue, the tissue. सही है? Actually, for clinician, जो आप आप में से जो students हैं, they are actually clinician scientists or clinician academics. Uh, the what for me, I would say that the practical consequence is that biomaterial development will become more data intensive. That means that data will be used to study which biomaterials will be more preferred. And I've already written it down. Okay, what is already plausible from the broader regenerative medicine literature is AI can predict MSC differentiation, immunomodulation function, and therapeutic potential from complex imaging and omics data. कि आर्टिफिशियल इंटेलिजेंस डेटा इतना अवेलेबल हो गया है हमको कि मेसेंकाइमल स्टेम सेल डिफरेंशिएशन बता देगा, इम्यूनोमॉड्यूलेटरी फंक्शन बता देगा. सही है. In one 2025 example, an AI method predicted MSC differentiation tendency with 90.6% accuracy, देखिए आप, and 80.2% for conventional marker-based methods. Hybrid physics plus AI systems are being used to predict drug release from the biomaterials and design response. 4th generation smart materials की बातें हो रही हैं. तो this was, again, I can share the resources with you कि कहाँ से मैंने information ली है, but it has actually changed. The paper was, I think it was advancing mesenchymal stem cell therapies and intelligent biomaterials for regenerative medicine. So this is already being happening. Okay, and this is the boxes that you're seeing here is the way that it has been used, reverse engineering the technology. What does it all mean? इतना बात करें हम लोग, क्या सही है? The next generation of endodontic biomaterial may be selected or even designed around patient phenotype, canal geometry, inflammation profile, and desired release connected, not just material availability. सही है? This is what precision medicine की जो बातें होती हैं, this will be the end result. Finally, a research roadmap for clinician scientists. When you start making your own scaffold, आपने बनाना शुरू करना है तो आपने reverse engineer करना है. Utilize all the resources that you have. सही है जी. And now what I have written over here is the phenotype the case. Standardized baseline disease stays using CBCT, sensitivity, perfusion, lesion metrics, and root developing. So, uh, एक्चुअली जो जितना कुछ हमने अभी तक पढ़ा है ना, तो आई वुड से कि दिस इज द कोर ऑफ व्हाट you can take from the from whatever papers that I've cited in this seminar today. Okay, phenotype based cases are first, they are better. Okay, number two, engineer the microenvironment instead treating scaffolds as just fillers. So you have to really engineer it
Sir,
mechanically.
what do you mean by phenotype?
देखिए phenotype is when you change so as you know that gingival phenotype जो होती हैं thick and thin. Okay, so every phenotype in endodontics is different. That means the microvasculature, the space, single multi-rooted multi canal, उसकी biology different होती है. So is it a bulbous crown? Is it a narrow crown? What is the canal morphology? So this, in terms of regenerative endodontics, we mean phenotype is referring to how the canal is. So iske andar, that is why I'm saying using CBCT to understand the canal morphology, and then you can have that scaffold based on that phenotype. सही है?
Okay, sir.
Got it? So the next thing is engineer the micro environment, compare the off-the-shelf immunomodulatory and provascular biometers, ideally with stage and responsive relief. उसके बाद है validate new platforms in more realistic preclinical systems. When we say validate the modern new platforms, I mean organoids, organ on a chip, exosomes, uh, and you need to try whether these strategies are actually working, not just in models, but you have to actually bring them to clinical realm and adapt them. Uh, Run smarter trial. That is very important. Use multi-center stratified AI-assisted mechanically annotated clinical trials rather than single-sited protocol variants. So rather than just having one single, relying on one a single center data, when you're doing clinical trials or clinical studies, go for multi-center studies and take evidence also from multi-center studies. Uh, Prior measure function is prioritize perfusion, sensitivity, biomechanics, patient-reported outcomes, long-term tooth survival, not radiographs alone. Okay, so not just taking periapicals, bite wings, or CBCTs. Take patient information, systemic information. How has there been a root canal done in the past? Was any therapy used? What was the outcome? Okay, so we are actually trying to, as I said, reverse engineering it using multiomics. Uh, so इसके अंदर what I've done is I've just tried to give you a research roadmap. Okay, use all these strategies and then devise it. क्योंकि पहले earlier on we just used to go like, okay, biomaterial कौन सा use हो सकता है? Okay, then we use a stem cell. Okay, what stem cell? Then a growth factor. Pretty much that's it. But now the way you think needs to be changed. तो अगर उसको simple terms में करना है तो rewiring की जरूरत है. To think, we need to think differently. Okay. Finally, this is just a take-home message that current regenerative endodontic therapy is clinically useful, but often delivers repair more reliably than full regeneration. सही है? So full regeneration नहीं हो रही. Okay. Blood cord remains the clinical scaffold benchmark, and more advanced scaffolds must outperform it in a biologically meaningful way. Whatever in vitro data suggests is that therapies, scaffolds, whether they are tubes, whether they are electrospun, freeze dried, along with angiogenic growth factors, they work. So yeah, but they are more in vitro and they haven't really been able to make up. And blood clot still remains the more clinically accepted method. The next major gains will come from vascularized immunomodulatory biometers, not from passive fillers alone. So, yeah, this is what I was talking about earlier when we were talking about the roadmap. Okay, it should be immunomodulatory. So you should be able to tune it based on the phenotype. Cutting edge in vitro systems, organoids, chips, root fragments, and pre-vascularized bioprints are now essential, not optional. You have to utilize biologically आपका जो data है of whether it's biofabrication, uh, microfluidics, organ on a chip. We have to look into these rather than relying on simple uh, past 20, 30, 40 years से जितनी भी टिश्यू इंजीनियरिंग हो रही थी वो was just okay, so scaffold ट्यून कर लेते हैं, okay, growth factor ऐड कर लेते हैं, but now things are changing. AI is most valuable when it strengthens evidence, retrieval, prognosis, prediction, and rational material design under expert supervision. So, जब भी ये use, whenever you are using it, take that data or information with a pinch of salt. मतलब don't trust it blindly. Okay, do your due diligence. मतलब आप खुद देखिएगा कि उसमें उसमें जो evidence उसमें दिखाया है, is it clinically relevant? Is it actually viable? So make sure you are able to do that. This would be the end of our session for today. अगर कुछ questions हैं, please feel free to ask. Let me know what you think. We will be left with periodontal tissue engineering. Then उसके बाद I can send out your assignments. सही है?
थैंक यू सो मच सर, या प्लीज लेक्चर और स्लाइड्स सेंड कर दीजिएगा।
जी 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 कर दूंगा। Okay. Any questions? We will try to get a speaker for periodontal tissue engineering that can cover about that'll be the last of it.
Sir, I missed the lecture on exosomes, so do we have a recording of it?
हाँ वो recording है, Dr. Paras की recording है. I have uploaded it and you can always see that. I can share with you. I think in fact the link is also shared in the
the group?
group.
Very check.
इस group में है.
Okay, sir. Okay. ठीक।
So if you want, you can reach that. Okay.
Okay, sir. Thank you.
You're
I'll
welcome.
recheck.
Thank you. Thank you. Thank you.